Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. My name is Zach Caseberg. I'm your tutor, your coach, your guide along the path to passing the RD exam. My biggest passion is to help RDs and RDs to be just like you to know how to effectively pass the CDR exam. And if that sounds like you, then hey, you're in the right place. When you're taking the exam or on your exam day, one thing I need you to remember is to breathe, obviously. I know you've heard that before, it's an old adage, but the reason you need to breathe is to remember to keep yourself calm, cool, and collected as you encounter each one of those questions. And secondly, it's going to help to serve as a little reminder about what your lungs do should you encounter any type of respiratory or pulmonary questions as you kind of remember what the function of those lungs are. I'd like to talk today a little bit about your respiratory system and tie that into some MNT with practice questions to really make sure we understand all we need to know when it comes to this system. Your pulmonary system is going to include two areas. You have your upper and your lower respiratory tract. That upper respiratory tract will be things like your nose, your nasal cavity, your sinuses, your larynx, and your trachea. The lower area is going to be where our lungs are, our lungs, our bronchi, and our alveoli. Let's talk about these structures just a bit more. The trachea itself, that's the airway that carries air into the lungs, right? And then it splits, it kind of branches off to the right and the left bronchi, which continue branching into small little bronchioles. You can probably picture this, right? At the end of the bronchioles are these little almost like pieces of cauliflower florets, I think. And those are your alveoli. This is the most important structure to remember because the alveoli are where the actual gas exchange occurs in your lungs. Oxygen moves into the blood, carbon dioxide moves out to be exhaled by the lungs. Within those alveoli, you have these little capillaries, all these little capillaries that are in there, very, very small blood vessels. And that is where the actual gas exchange is occurring. Remember that for your pulmonary system and the functions that it has is going to be for doing things like gas exchange, but also helping with things like acid base balance and providing immune system defense for our bodies. When we go through lung conditions, I need you to really stick to that anatomy and physiology we just covered because that understanding is really what's going to help you to apply that knowledge to questions. Because we need to know hey, this is what happens when the lungs are working normally, but the MNT is about what happens when they're not working normally. The primary function of the lungs, as you kind of heard me say, is gas exchange, bringing oxygen into the body and removing carbon dioxide. So, if the lungs are damaged, what happens? Gas exchange is certainly going to be affected, right? The body has difficulty getting enough oxygen, and then it also, secondly, has difficulty removing that carbon dioxide. Now, this is how this connects to acid base balance. Remember, carbon dioxide combines with water to form carbonic acid. So, whenever I say someone is retaining carbon dioxide, I usually just mean they're retaining acid because they kind of follow each other. Because of this, many patients with pulmonary disease can develop respiratory acidosis. This also connects to the immune system as well. The lungs are so constantly exposed to the environment, they help to protect the body from different pathogens. But when they're impaired, those patients have a hard time clearing those infections and maybe at a higher risk of getting sick or staying sick longer. This is especially going to be important as we move into the MNT. Now, I want to give some just general guidelines when it comes to medical nutrition therapy. Really basic stuff that's going to apply for almost all of these conditions. Eating pattern. One, I would recommend to any type of respiratory patient that, yeah, really anyone, that I'd be recommending that they do several small meals per day. Energy dense, small meals, several throughout the day, mostly because they can get very out of breath as they eat large meals and as they get full. So, by doing smaller meals, we can get more energy packed into each of those little meals. We also recommend that when they're going to be taking those meals, that they take liquids separate. This is usually a recommendation I would give to a pulmonary patient is just saying that, hey, drink your liquids outside of meal times because we don't want you to drink water or liquids or, carbonated beverages that are going to compete with food in your stomach that are going to make you feel more full. We don't want that to happen. So let's drink the stuff outside. Level of kilocalories is really going to depend on how severe or stressed that patient is, as well as the other comorbidities and other things that could be going on. But when we talk about macronutrients a little bit, I do need you to remember a little piece here, and that's about respiratory quotient or RQ. What RQ does is it tells us the source the body is primarily oxidizing for energy. So to kind of set this up for you, whenever we go through the digestive process of breaking carbs into glucose, fats into fatty acids, proteins into amino acids, whenever we do it, we're doing that and taking those substrates to enter metabolism. The body consumes oxygen to do that. It consumes oxygen and it produces carbon dioxide. And this is what your RQ reflects. What it is, it's the amount of carbon dioxide produced on top divided by how much oxygen is consumed. Does that make sense? So when it comes to the RQ, the way you need to think of this as each one of these macros is going to produce a certain amount of carbon dioxide, some for good and some for bad here. So let's make sure we understand this. The RQ goes from a range, maybe let's say 0 to 1.0. Let's just kind of use that. 1.0 is really the max that we'll see. And what 1.0 represents is one carbon dioxide produced for every one whole oxygen used. Makes sense, right? So then if we look at RQ of each of the macronutrients, if you look at carbohydrates, carbohydrates are the highest of the high. They produce one whole carbon dioxide for every one oxygen consumed. This is a bad thing. We do not want to be producing lots of carbon dioxide, especially for a respiratory patient. For our fats, this is the one where we produce the least amount of carbon dioxide. So the RQ for fats is zero point 0.7, meaning for every one oxygen I use up, I'm only producing zero point 0.7 of a carbon dioxide. So you can see the difference between fats and carbs because in carbs, I'm really producing a lot of carbon dioxide, but in fats, I'm not producing as much. Protein is right between those two. It's about zero point 0.8, and a mixed diet is about 0.85, considering most people eat a little bit more carbs, right? So here's all you need to take from this just for exam day. If a patient is eating a lot of carbohydrates, they're going to produce a lot more carbon dioxide. So it's going to be a high RQ. If a patient is pulmonary and they are eating lots of fats, which would be a better option, they're going to produce less carbon dioxide and they're going to have a lower RQ. So for that patient with COPD, for instance, yeah, we want them to be eating more of a fat diet instead of carbs because then it's going to produce less carbon dioxide. Hopefully that all makes the most sense to you. Now that you're stuck in the pocket for that, let's take this into the actual MNT that we have here. We're going to start with the chronic stuff and we're going to move on to more of the acute after that. First one here is chronic obstructive pulmonary disease, also known as COPD. With COPD, there's two major conditions you need to know: chronic bronchitis and secondly, emphysema. They have different mechanisms but similar nutritional concepts. Chronic bronchitis, break down that word for me. Bronchi, airway, itis, inflammation of. So, bronchitis is inflammation of the bronchial tubes. Patients typically are experiencing a productive cough, shortness of breath, and long term respiratory symptoms at that point. The most common cause of this bronchitis is cigarette smoking, but exposure to secondhand smoke or environmental chemicals can also contribute. Emphysema is our second one of COPD. Emphysema is worse than that of bronchitis because you get actual destruction of the lung tissue, real bad. Over time, that chronic inflammation can lead to permanent enlargement and destruction of the alveoli. So, those areas you do the gas exchange, oh no, they're not working so well anymore, are they? So, now you can kind of see how this all fits together. So, for COPD, here's going to be our general guidelines that we're going to give. Major nutrition goal: prevent malnutrition. We don't want someone to take this condition, which otherwise seems livable, and end up with malnutrition as a result and get much sicker. Their risk for infection is going to go up if they're malnourished. It's not going to be good. Breathing takes a lot of energy. Appetite may decrease. Fatigue might make eating difficult. So, all of these put this patient in the column of, hey, you're at risk. An RD will want to make sure that they do a proper nutrition assessment in this case, looking for things like weight changes, loss of lean body mass, loss of fat mass, if any of that was indicated as well. And on the intake assessment, we'd ask things, how is your appetite being affected by your condition? Are they able to consume enough food? And also, I need you to think about a few things that COPD can also lead to, one of which could be a risk for osteoporosis. Now, this can be due to a bone mineral density issue, vitamin D deficiency, poor intake, inactivity, limited exposure. All of these can factor into bone mineral issues because maybe they're not being as active and maybe they're not going outside to get as much vitamin D because it's so hard to move around and do things, right? A lot of patients with COPD, they'll also take corticosteroids, right, to help fight off infections. Corticosteroids can also decrease your calcium absorption, increase your urinary calcium loss, increase your parathyroid hormone activity, and all of these add up to just say, hey, you're going to have some bone mineral density issues. For other nutrition recommendations, more of the classic things. For calories, I just want a high calorie diet. Probably something around 30 to 35 kcals per kilogram per day if they have a relatively normal BMI. I want them to have a high protein diet, probably going to be around 1.2, maybe even up to 2.0 grams per kilogram per day for protein on that patient. We talked about how we want them to consume their meals, right? So small, frequent meals, energy dense, and getting those fluids in between meals so we don't compete for our fullness there. Hopefully, that was a good refresher on just the COPD, which is like a two for one in that case, too. Now, we're going to get a little more advanced here talking about cystic fibrosis. Something I've always struggled with is just talking about this topic. So, I'm going to do my best to give you what you need for your exam day. Now, CF is very different from many other pulmonary conditions because it's an inherited disorder. It's caused by a mutation in the CFTR gene. The CFTR protein helps transport chloride across cells. Under normal conditions, this CFTR protein would help with moving chloride out of your cells, helping water to follow that chloride through osmosis, and helping secretions like your mucus secretions that are all throughout your body stay nice and thin and normal. But with cystic fibrosis, that CFTR does not work properly. Your ability to move chloride out of the cell is impaired. Less water is being present to thin out those secretions, and mucus and secretions get very, very thick and sticky. That thick, sticky mucus is super bad because it can actually block organ function, including things like the liver, the lungs, the pancreas, the digestive tract. All of these areas are being impacted due to this thick mucus buildup. In the lungs, that thick mucus also makes it hard to clear things like bacteria, leading to things like chronic coughing, wheezing, lung infections. And in the pancreas, that mucus can even block pancreatic ducts. So it may cause pancreatic insufficiency, meaning those digestive enzymes that are coming from the pancreas to the GI tract, they're not getting there anymore, okay? Because they're blocked in a little bit like a parked car. So that's another example as to how those secretions are so affected through CF. For our MNT for these patients, we really want to focus on preventing malnutrition. The patients typically need a very high kcal diet, high protein diet, high fat intake, and increased sodium intake. Why though? Why high fat? Fat is very energy dense, and just like with other conditions, we want to make sure they get good energy dense meals. Many of these patients require pancreatic enzyme replacement therapy due to the pancreatic insufficiency I mentioned earlier. So, for that reason, we want to make sure that they're having high fat so they get plenty of fat soluble vitamins such as vitamin A, D, E, and K, because they're going to probably be a bit deficient in these anyway, just due to the fact that Under normal, when they don't have pancreatic replacement therapy, well, they probably weren't absorbing these vitamins very well. Now that they're on pancreatic replacement therapy, they're going to do a little better absorbing them, and so it's a good indication to have more fat in the first place. We would also want to monitor for things such as an iron and a zinc deficiency for these patients here too. And with CF, we always talk about we want to make sure they consume lots of salt in the diet, and that's mostly because as they're sweating, they lose additional amounts of chloride because chloride cannot easily move through the membranes of the cell like it normally would. And so they lose excess amounts of chloride in the sweat. And so they have this very sweaty brow. Their sweat tastes super, super salty. And that's kind of one way that they'll do a sweat test to see if someone has CF. Now, moving on to another condition here, pneumonia. We're going to get a bit more acute now in this phase. Pneumonia is inflammation and infection of the lungs caused by bacteria, viruses, even fungus can cause this. Aspiration pneumonia is one specific to us as a dietitian and to also SLPs, right? Aspiration can occur when a food, liquid, bacteria enters the airway instead of going into the esophagus or the stomach. Let's talk about swallowing a little bit here. Under normal circumstances, when I swallow water or food, what happens is it could travel straight down, but this epiglottis is like my hand here. It closes and it closes to allow food to slide down without going into my lungs. It's like a little flap that just closes to cover up my lungs and say, hey, we don't want any of that food or water going down here at this phase. So when I swallow, the epiglottis closes and it'll help to cover up my lungs and protect it almost. A lot of patients who have strokes, Parkinson's, head injuries, neurological issues, they're going to have issues with swallowing, and that epiglottis ends up being affected there. So when they swallow, they typically will aspirate liquid or food into their lungs, which further just develops into a bacterial infection. If you've worked in the clinical setting, you know this is a very common reason as to why we have to do enteral nutrition on some of these patients with those conditions. Now, pneumonia can cause dyspnea, which is difficulty breathing, fever, cough, wheezing, fatigue, higher risk for infection, inflammation, and even fluid buildup in the lungs, which can affect gas exchange. For MNT, if a patient has pneumonia and they're not ventilated, I want you to think of these things: high kcal diet, high protein, small frequent meals, energy dense foods. The goal is just purely to prevent malnutrition. But if the pneumonia progresses and a patient requires to be ventilated, the nutrition becomes more complex. This is going to kind of lead into our next syndrome that's related to pneumonia, but it's called acute respiratory distress syndrome. Not a disease, it's a syndrome that happens as a result of a disease. It's a severe acute inflammatory condition of the lungs that's caused by major stressors, such as pneumonia. COVID 19 was a really common causer of ARDS in this case. Sepsis, trauma, these are all reasons. Mechanical ventilation. The lungs become very severely inflamed, and your ability for normal gas exchange is really impacted. The key problem is that the patient cannot effectively move oxygen into the blood and remove the carbon dioxide because their lungs just suck. So they're showing a lot of those same signs and symptoms as that of pneumonia, but maybe I'll include like shortness of breath, low O2 levels, respiratory acidosis. It's getting very bad and they could die as a result of this. So, since this patient is in a state of acute stress, we're always going to be doing increased calories, increased protein, adequate fluids, and of course, remembering protein to help prevent any muscle breakdown at that point. We'd want to make sure they're getting adequate amounts of fluid, not getting too much, because that water is going to help to thin out those thick secretions. If a patient has ARDS and they can tolerate oral intake, that's ideal. However, most patients with ARDS are going to require intubation and mechanical ventilation, meaning they cannot eat orally any longer. They have a tube down their throat. In this case, when a patient is ventilated, enteral nutrition is typically required. For these patients, we would want to make sure we use predictive equations to estimate calorie needs. If we could, we'd rather use indirect calorimetry because it could get a more accurate way to assess that. Those predictive equations, by the way, remembering that they would consider things in the body such as the patient's temperature, the patient's minute ventilation, which is a ventilator setting, the patient's weight, the patient's height. These are the things that would be included to get a more accurate response as to what the patient's needs are going to be. Also, make sure we're going to account because the patient who's on ventilation almost always going to be um, under some state of sedation. So when they're being sedated, commonly with propofol, propofol has calories in it. So it does make it more complex when you're trying to calculate the nutrition needs because you have to account for the propofol the patient has. With ventilating a patient, we want them to eat soon because we want them to not become malnourished, obviously, at that point. So that kind of speaks for itself. But how quickly do we do this? How fast do we want the patient to get enteral nutrition? Typically, in the first 24 to 48 hours, we would want to initiate those enteral feedings. Perfect there. That's Aspen's recommendations, right between 24 48 hours, as soon as possible. When the patient is hemodynamically stable, meaning their blood pressure is stable, we want to get that enteral nutrition started for them. Okay. As long as they can tolerate it, we would just continue to build up to their goal, hopefully reaching about 60% of their needs by a week after their ventilation. So we know that they're not becoming too malnourished at that point. But basically, from that, for ventilation, just make sure we're calculating the needs effectively and initiate that feeding within the first 24 to 48 hours, and you'll be good there. Now, let's apply what we learned today to some practice questions, starting with number one. Number one, a patient with untreated COPD who has slowed and labored breathing would be most likely to present with A, respiratory acidosis, B, respiratory alkalosis, C, metabolic acidosis, or D, metabolic alkalosis. A patient with untreated COPD who has slowed and labored breathing would be most likely to present with which? For A, respiratory acidosis. So, respiratory acidosis would be a scenario where the patient's pH is low, meaning it's acidic, and it also would be saying that the lungs are what's causing this. When I look at this question, COPD, slow labored breathing, tells me that the patient is going to be breathing very slowly and retaining a lot of carbon dioxide, which we said is acidic, right? I'd like answer A. I want to hold on to it because I think it's a good fit. B, respiratory alkalosis. So this would be the opposite. The patient's blood is not acidic, it's alkalytic. So they would not be retaining too much carbon dioxide. Their carbon dioxide would be too low in this example. This doesn't sound like the COPD patient to me because the COPD patient has high carbon dioxide, not low. So B is going to be out for me, folks. C is metabolic acidosis and D is metabolic alkalosis. I'm going to rule both of those out because I've already determined that this is a respiratory issue. Metabolic acidosis could be in the running just based on the acidosis piece. But no, I don't believe C and D are good because our physiology, or our etiology, I should say, is not a metabolic issue. So I would say for a patient with untreated COPD with slowed and labored breathing, they'd be most likely to present with respiratory acidosis. Answer A. Number two, a patient with acute respiratory distress syndrome has just been ventilated and they are hemodynamically stable. Which of the following would be the next nutrition prescription for the patient? A, parenteral nutrition within 48 hours. B, oral diet with oral nutrition supplements. C, enteral nutrition within first 48 hours. Or D, maintain patient as NPO for 3 days. A patient with ARDS has just been ventilated and they are hemodynamically stable. Which of the following would be the next nutrition prescription for the patient? For A, parenteral nutrition within the first 48 hours. Maybe. I'll put a little question mark by it and I want to see my other answers. B, Oral nutrition supplements with the oral diet, I think we should rule this one out because what I've determined is they've just been ventilated. They're probably not going to be too good at eating orally because they have a big tube down their throat. So I think I'm going to rule out answer B. Oral diet's not going to work. C. Enteral nutrition within first 48 hours. I like this within an answer. I think it's nice and prompt, and I'm going to hold on to it. D. Maintain patient NPO for 3 days. Oh no, I don't think I want to do that, right? That seems like a long time to keep them NPO, and to what gain? I'm going to rule out answer D for this. So if I look at A, parenteral nutrition within the first 48, or C, enteral within the first 48, I would say C, because the patient's GI tract seems to be working, or at least they haven't told me that it's not working. So I can use that GI tract. If it works, use it. So I would say enteral nutrition within first 48 hours would be our best fit here. Number 3. A patient with COPD who weighs 60 kilograms and is 1.8 meters tall should consume blank grams of protein per day. 48, 60, 72, or 150. So, with a COPD patient who weighs 60 kilograms, I recommended right around 1.2 grams per kilogram if their BMI is normal. I looked at their BMI, and their BMI is borderline low, maybe normal of 18.5. So, let's do 60 kilograms times 1.2 and see which answer fits. No, it wouldn't be A, 48 grams. No, it wouldn't be B, 60 grams. C, 72 grams seems like a great fit. And D, 150 is way too high. So for number 3, a patient with COPD who weighs 60 kilograms and is 1.8 meters tall, should consume 72 grams of protein per day. That wraps up today's lesson, students. I hope you watched, listened, learned, and enjoyed today's show. Remember that passing this exam is a journey. We all need assistance along the way. Do me a favor, hit the subscribe button if you haven't, tell other studying students, rate, review, subscribe, help spread the word, and remember, as always, happy studying, RD to be.